This talk is about respiratory therapeutic measures, including artificial airways, mechanical ventilation, diagnostic procedures, and surgery. We are specifically going to talk about some common therapeutic measures such as thoracentesis, artificial airways, mechanical ventilation, including tracheostomies, intrathoracic surgery, and chest tubes. A thoracentesis is used to remove fluid from the pleural space. In the lectures that are done with restrictive pleural diseases, we talk about pleural effusions, and in the infectious disease portion, we talk about empyema, and a thoracentesis could be used to remove fluid in either one of those cases. It can be either therapeutic or diagnostic. Therapeutic means you're removing the fluid to make it easier for the person to breathe and to have their lung expand more fully. If it's diagnostic, that means that they are pulling the fluid off and they're going to send it for tests to figure out just exactly what the fluid is. Is there infection there? Are there cancer cells there? And if it is diagnostic, you may have to assist with gathering the fluid specimens. This is done with a local anesthetic. It's a large bore needle and it's inserted from the back. There's a diagram here in a little bit. When it's over, the dressing is Vaseline gauze. The vitals are taken afterwards, similar to post-op vitals, and of course you want to make sure and assess for respiratory rate, excursion, and oxygenation, because a pneumothorax is a complication. You also want them to lay on the unaffected side afterward to allow for expansion of the affected lung, and you really want them on bed rest for at least an hour afterwards. Also, afterwards, they will do a chest x-ray to check for a pneumothorax. This shows patient positioning for a thoracentesis. You've got fluid in the bottom of the left lung, the pleural space, filled with excess fluid, and then that pushes up the left lung and it can't expand as much, and therefore there's less area for gas exchange. And so what they do is they have the person sitting upright, leaning forward on a bedside table, and they put that large bore needle there into that pleural space where the fluid is, and then it collects in a bag, a syringe, sometimes a vacuum bottle outside the patient's body. And the physician just stands there with the needle until the fluid has drained off, and then when they take the needle out, they slap that Vaseline gauze on there, hopefully to put an airtight seal there. Endotracheal intubation and tracheostomies. So an endotracheal intubation is a fast way to establish an artificial airway when it's needed. Endotracheal intubation means that an endotracheal tube, or an ET tube for short, is inserted into the trachea either through the nose or the mouth with the use of a laryngoscope. It's a scope with a light on it that they use to open the airway, push back the vocal cords, or actually visualize the vocal cords, and then they're able to pass the tube through the vocal cords. A tracheostomy, on the other hand, is a surgical incision into the trachea for the purpose of inserting a tube through which the patient can breathe. So the picture that's here is of an ET tube, and you'll notice at the bottom there is a little cuff that they inflate to seal off the airway once the tube is in place, much like the cuff on a cuffed trach. So why would you do a tracheostomy, which is it's not totally a permanent procedure, but it's certainly more of a permanent and invasive procedure than an ET tube? Well, first of all, let's talk about ET tubes. So they're really good for quick establishment of an airway, but over time, uh, that balloon can erode the airway, and it's not good to leave them in for a very long period of time. And so if you have somebody who's going to be on the vent for, a week or two, usually at that point in time when they realize they're not going to be able to get them off the vent, they will put a trach in. So the purpose of a tracheostomy is to assist or control ventilation by a mechanical means over a long period of time. Functions just exactly the same as an ET tube, only it's better for a long period of time. The other thing a trach is good for is it facilitates suctioning of secretions for people who are unable to cough. It's much easier to suction through a trach than it is through an ET tube because you can get down lower. Trach also prevents aspiration of oral and gastric secretions. So if you have somebody who's unconscious or paralyzed, that's useful. And it's also useful to bypass a constricted or an obstructed upper airway. Trach decreases dead space. So remember we talked about dead space is any space in the upper respiratory system where gas exchange doesn't take place. So the nose, the mouth, the oropharynx, the nasopharynx, and the trachea. So the farther down you go, the less dead space there is. So a trach decreases the amount of space and air has to travel through before it gets to the place where there's gas exchange. And you think, well, that's not such a big deal. Well, actually, if you're only moving a little bit of air at a time, as in somebody with COPD, that is a big deal because just 50 cc's of space can make a big difference. The other thing that a trach is really good for is obstruction. When you have obstruction or constriction of the airway from edema, presence of a foreign body, a tumor, a surgical procedure involving the neck, like a radical neck. We're going to talk about throat cancer. When you have burns, facial trauma, chest trauma, anything like that, a trach is really good to keep and maintain an open airway. There are different kinds of trachs. You've seen these in the lab. There is a cuffed trach, which has the little balloon in it. And you can see on the right there's the little pilot balloon that you use to put the air in to blow the balloon up. There's also a foam trach, which exerts minimal tracheal pressure as opposed to an air-filled balloon. You can have single or double cannula trachs. You can also, and with those inner linings that you take out and discard when you're cleaning the trach. And then you can have a fenestrated trach. Fenestra is the French word for window, and there are little windows in that trach, and that helps people to speak. The cuff on a trach ensures that only air passes through the trach, no secretions, and it also protects your airway against the aspiration of secretions from above. So a new tracheostomy requires very specialized nursing care, especially if mechanical ventilation through the tube is required. You need to monitor continually for signs of respiratory distress, and the immediate post-op period on a new trach focuses on maintaining a patent airway and observing for hemorrhage. This is very important. Two huge priorities here: maintaining a patent airway and observing for hemorrhage. During the first 24 hours, the patient is monitored continuously for signs of respiratory distress. If they can't cough and remove the mucus in the drainage, tracheal suctioning is necessary. If the lumen is not kept open, the patient will suffocate. This is their only way of breathing. Suctioning is done with strict sterile technique on a fresh trach to prevent infection. And you also need to make sure you've got adequate humidification of the inhaled air and hydration of the patient to help thin the secretions. Remember, you're bypassing the nose, which is where air is humidified, and so having that extra humidification will help with secretions. When suctioning a patient with a trach or an endotracheal tube and using a sterile suction kit, you need to ask for help. You learned this in your skills lab, but I'm going to repeat it here again. Ask for help to deliver oxygen before and during the procedure as needed. Oxygenation of the patient will prevent desaturation, and the assistance of the helper helps you to maintain sterile technique. So you pre-oxygenate them and then oxygenate in between suction passes. If you've got somebody on a mechanical ventilator, they can be pre-oxygenated with the ventilator, and they also may have an inline suction device attached to the airway. So you really need less hands for that. But if you don't have that, you for sure need a helper. Signs that somebody needs to be suctioned include increasing crackles or wheezes, dropping saturations. Very important things to observe. Increasing crackles or wheezes, dropping sats, any respiratory distress you see, increase in respiratory rate, and sometimes they'll even cough. There's a lot of psychological support that nursing needs to provide with people with a new trach. It's very scary. You don't get a tracheostomy unless you have some really serious problems. And when you, of course, have a tracheostomy, that impairs your ability to communicate. And so psychological support, communication, and then also they're going to need some rehab afterwards to learn how to function with the new trach, if indeed it is to be permanent. A passing-muir valve redirects airflow through the vocal cords, mouth, and nose, enabling voice and improved communication. So this basically allows people to speak. It's a speaking valve. It's placed on the hub of the trach or in line with a ventilator to redirect airflow through the vocal folds. Years of evidence-based research has shown that a passing-muir valve offers patients numerous clinical benefits beyond communication. It's a really good device, and it's something that you'll see people who have long-term tracheostomies use quite a bit. Mechanical ventilation is something that you will see quite a little bit of when you're at Kindred. I won't go through this a lot. You have an entire clinical prep on this when you go to respiratory. There are a number of different modes of ventilation depending on what the patient needs. So assist control or continuous mechanical ventilation delivers the vent delivers a breath each time the patient begins to inspire. So the patient is controlling their respiratory rate, and when the vent feels that, it delivers a breath. If the patient doesn't breathe, then the vent will determine a predetermined set of number of breaths per minute. So in other words, if you have somebody set in an assist control of 12 and the person isn't breathing 12 times a minute, the machine will go ahead and kick in for them. You can have SIMV, which is synchronized intermittent mandatory ventilation. So it lets them breathe independently, but it also delivers a minimum numbers of breaths per minute, and it synchronizes to the patient's own ventilatory pattern. It's sort of a fancy assist control thing. Pressure support is something that provides positive pressure on inspiration to decrease the work of breathing. This is a really important thing to do when you've got somebody who needs to rest, when they are in respiratory failure and they just need to rest. Breathing takes so much work. You just have no idea unless you are in a situation like this with damaged lungs. PEEP is positive end expiratory pressure. What this is it's positive pressure at the end of expiration. It keeps those small airways open, keeps them from collapsing, which is atelectasis, and so keeps them open for more gas exchange. Once they've collapsed, it's way harder to pop them back open again. And so the key here is keeping them open so that you don't have to do the work of popping them back open again. It just keeps more area open for gas exchange. CPAP is something that we'll talk about in a lecture on obstructive sleep apnea. It's continuous positive airway pressure on inspiration and expiration. Is just continuous pressure, and it keeps the alveoli open in a spontaneously breathing patient. This does nothing to breathe for the patient. It's just continuous pressure. BiPAP, on the other hand, is a machine that is programmed to deliver air at a specific pressure on inhalation and then a specific pressure on exhalation. So it's bi-level. It's 2 levels of positive airway pressure, a little bit more on inspiration and a little bit less on expiration. So when the machine senses when the person inhales and exhales. This is usually what you'll put somebody on before you intubate them and put them on a ventilator. This is like the last resort to help somebody breathe and to keep them off a ventilator. And then really non-invasive positive ventilation is like BiPAP. It's kind of the same thing. It's trying to keep somebody ventilated without intubating them. The dangers of mechanical ventilation, or maybe the complications of mechanical ventilation, are listed below here. Barotrauma, you can actually get trauma from extra pressure to your lungs, and it can injure your lung tissue. Oxygen toxicity, too much oxygen for too long a period of time. Impaired cardiac output usually happens when you have extra pressure involved. So if you've got, let's say, a lot of PEEP, positive end expiratory pressure, the pressure in your pulmonary vasculature is higher than normal, causes your heart to work harder than normal, and can impair your cardiac output. Infection, obviously. If you've got somebody who is being suctioned a lot and perhaps people aren't careful about their sterile technique, fluid retention, gastric distension from all of the extra air. Sometimes when you get, it's just like with CPR, if you blow too much or too hard into the patient's lungs, that epiglottis will open and it'll go down into your stomach. And then also GI bleeding. You can get stress ulcers from mechanical ventilation. It causes a lot of stress on your body, activates the sympathetic nervous system, and you can get stress ulcers. So usually anybody who's on any kind of mechanical ventilation will also be on some sort of gastric protection like PPI. Ventilator-acquired pneumonia is a special type of hospital-acquired pneumonia, and the Center for Disease Control and Prevention, the CDC, recommends a bundle of nursing interventions to try to prevent this disease. First of all, elevating the head of the bed to 30 to 45 degrees. You don't ever want to lay somebody on mechanical ventilation flat if you can possibly help it. You want to continuously remove the secretions, so frequent suctioning is important. This is not something you would necessarily do. This is a respiratory thing, but changing the ventilator circuit no more than every 48 hours and washing hands before and after contact with every patient. So you don't want to break that ventilator circuit if you don't have to. And of course, always washing your hands just goes without saying. Sometimes the facilities will add to that bundle of care, and they may want you to check the residual volume of the nasogastric tube frequently to make sure that you don't have a stomach full of secretions. They may also want you to provide oral care with chlorhexidine. Oral care is so important in preventing ventilator-acquired pneumonia. Big nursing responsibility. They may also want the person on DVT prophylaxis, which is really common, and then also, as I mentioned earlier, peptic ulcer prophylaxis. So you'll usually see these people get low molecular weight heparin and also a PPI such as pantoprazole. So this is just a few more nursing care things. Some of it's common sense, actually. Of course, checking the order every shift and then checking the ventilator for the proper settings. You may think this is a respiratory thing, and it really is kind of a respiratory thing, but stuff in those rooms gets bumped, and people push buttons and change things, and they don't push them back. So it's just a good idea to make sure when you get there that things are doing what they are ordered to be doing. Always check to make sure your alarms are turned on. This is a thing that is a real problem when people turn the alarms off. In fact, there was this respiratory therapist at a facility a short while back who would go around and turn the alarms off during the night so that they didn't get bothered. And there were quite a few things that got missed during the day, patients who got in trouble that nobody realized because their alarms were off. So needless to say, that person was reprimanded for that, and that is not a good policy. Always keep those alarms on. And then keep the tubing clear of pooled water. Respiratory therapy will show you how to do this, how to empty the water in the tubing, because when it condenses, and when you turn somebody and there's water pooled in the tubing, then the water gets put back into their airway, and that is not a good idea. So more nursing care here. You really need to understand that these people can be panicked. If they are awake and alert and they know what's going on, it's very scary to be hooked up to those big machines, to not be able to breathe on your own, or to feel like you are breathing against your normal breathing pattern. They need to be encouraged to relax. Sometimes they'll be given medication so that they can relax. Sometimes they actually give people paralytics because they're so anxious and they buck the ventilator so much. Sleep is really important. Pain. They can't talk to you. They can't tell you you're in pain. They're in pain. And so if they're not communicating with you, watch for those nonverbal signs of pain, and make sure that you're giving them the pain medication that you need. Suction as needed, but remember, suctioning can be frightening. You are literally sucking the air out of them. And so be sensitive to that and really try to help them remain calm, stay and talk them through it, and stay afterwards if you need to. Explain every single thing you're doing. And then also facilitating communication, because if they're on the ventilator, they're not going to be able to talk. And so you need to find a communication board, piece of paper and pencil to write, whatever it is that they can use to communicate with you. So thoracic surgery. A thoracotomy is an incision in the chest wall. Sometimes they do a pneumonectomy, which is to remove an entire lung. Sometimes they will do a lobectomy to remove part of a lung. A resection is part of a lobe, and then they can also do lung transplantation, and sometimes they will do a combination heart-lung transplantation, just depending on what's going on with the patient. There is such a thing as video-assisted thoracoscopic surgery, or VATS. It's a less invasive kind of surgery, and it's pictured here. They put a number of different endoscopy incisions and tubes into the person, and it's much less invasive. Thoracotomy requires a huge chest incision and takes a long time to heal. It makes it very hard to take deep breaths, and so this is a much better alternative when you can use it. It's used for biopsies, it's used for staging and treatments of tumors. One more thing about lung transplants, I guess, is why would you do a lung transplant? Well, you can do it for cystic fibrosis, you can do it for pulmonary artery hypertension, you can do it for alpha-1 antitrypsin emphysema. So that's a genetic emphysema that we talk about later when we talk about COPD, and also bronchiectasis. You can do one lung, you can do both lungs, and as I mentioned before, you can also do heart and lungs together. So preoperatively for thoracic surgery, you need to teach the person what to expect. They will probably wake up in an ICU and they may be on a ventilator. So make sure that they know that, because it's frightening enough without knowing what to expect. You will most likely see early ambulation as early as possible. Position changes, really important. Use of incentive spirometer, turning, coughing, deep breathing after the ET tube is removed. Obviously, coughing and deep breathing exercises really can't be done with the ET tube there, but you can turn them when they're on the ventilator and make sure that you are suctioning and trying to keep those secretions moving. And so they need to know that this is what's going on, this is what to expect. And then not only to know what to expect, but to know how to do the deep breathing exercises, how to do the coughing, and how to use the incentive spirometer. Postoperatively, most likely again will wind up in the ICU, so they'll need constant monitoring, and more often than not, they will come out with chest tubes. So chest tubes are a form of closed chest drainage. The purpose of this is to drain air, fluid, and blood from within the pleural cavity, and by doing so, you allow for gradual re-expansion of the lungs. What nursing assessments should include is the respiratory status of the patient is the first thing. This is the big priority, because you need to make sure that they are breathing at a normal rate, that their SATs are good, and that they're not in any respiratory distress, because that could indicate either the chest tube's not working or there's a problem with the tube. The other big nursing responsibility is the chest tube site. You need to make sure that you're looking at the site where the chest tube is inserted, and you need to look at the tube. Look all down that length of tubing for kinks. Very important you don't have kinks there. And then finally, you also want to look at the amount and character of the drainage that you'll see in the collection chamber. This is what's draining out of the lungs. This illustrates sites of insertion for chest tubes. If you've got a pneumo, it'll be high up, and that will be the kind of chest tube that will be used for removal of air to reinflate the lung after a pneumothorax. If you have surgery, the chest tube will be down low, and that is used for the removal of fluids. It will be connected to a drainage apparatus and will have a long tubing, and you'll see a picture of it here in a minute, but there's a chest drainage system with 3 different compartments, and this removes fluid, and it also removes some air as well. So a closed chest drainage system is a one-piece molded plastic system. This is something that you probably won't see right now while you're practicing as an LPN, but for whatever reason, it seems like there's always questions about this on ATIs and on NCLEX practice questions. I don't know what you'll get on the NCLEX. So anyway, I feel like I ought to go over it, but I don't think that this is all that important for your practice once you graduate. So anyway, there's 3 chambers. There's a water seal, and what happens is trapped air from your lungs escapes the pleural space and bubbles up in this water seal. And the bubbling occurs on exhalation until re-expansion. So it's like intermittent bubbling. Then you'll also see tidling, which means the water level goes up and down every time the person breathes. So what you'll see is you'll see water going up and down and bubbles when the person exhales. That's normal. Constant bubbling all the time, check the tubing for kinks because you've got something amiss there. Then the second chamber is a suction chamber, and that is connected to suction. It's usually negative 20 centimeters of water pressure, and there is a little bit bubbling in that chamber if there's water in it. So that chamber will bubble all the time. So you've got one chamber, intermittent bubbling, going up and down with breathing. Second chamber, if there's water in it, bubbling all the time. Third chamber, drainage chamber. This is when you catch fluid, blood, pus, whatever, draining from the pleural space. It is not empty. What you do is you mark it for your I&O for the shift, document it as output, describe it in your nursing notes, and then move along. This is closed. It's never open because of the risk of infection. Nursing care for a patient with a chest tube includes both assessment of the patient and assessment of the draining system. For the patient, of course, lung sounds should gradually return if indeed you do have pneumothorax and you don't have full expansion on one side. Your dressing should be intact and there should be no crepitus, no crunchy sounds, sort of like bubble wrap. That means you've got subcutaneous emphysema. That's not a good thing. Got to notify somebody immediately about that. You always want to check the tubing for kinks, make sure the connections are secure. You don't want any dependent loops where the drainage is just sitting in that loop and not going down into the collection chamber. You always coil the excess tubing on the bed. Don't ever let it hang down and don't ever let it hang on the floor. And then the closed drainage system itself, you always are checking the water seal, the level of the water. You want to look for tidling. That means up and down with breathing, or bubbling, which happens during exhalation. You want to check the suction chamber to see that there's constant bubbling there, make sure the suction's on, check the amount of drainage and mark it every shift. And if indeed you see constant bubbling in that water seal chamber, check the tubing for kinks. Finally, here's a picture of the disposable water seal drainage system. What you'll see here is you see in the left-hand system is your water seal chamber. That's the thing that will bubble intermittently, maybe tidal. Then you will see in the middle your suction chamber, and then you will see on the right your drainage chamber. And then where you would mark the drainage, the mLs are there, and you can go ahead and mark that every shift. And it should obviously be decreasing as the healing process takes place. You've got two tubes coming out of the top. One tube is coming from the patient, and that is the one that goes into the, looks like it goes into the drainage chamber. And then you've got one tube that goes to the suction that goes into the suction chamber.